You can begin.
Good evening and welcome all of you. Glad to see everyone here for today's session on caring for the caregiver. Before starting the session, let us have a small introduction about NMBF. NMBF Coffee Chats is a Christian service organization where we discuss relevant issues and topics that matter to our living as individuals and as a part of society. Its vision is kingdom in scope. I once again welcome you all here. Before starting the session, I would request Brother Abhijit to pray.
Okay, let's pray. Heavenly Father, maker and creator of us all, we thank you for this wonderful session, Lord. Thank you for all the people who've gathered here. Thank you for all the caretakers in the world. And we pray, Lord Jesus, that as a society, when we look at the caregivers, Lord, we will understand the sacrifice and pain and suffering, and we'll be able to extend support to this wonderful group of people, Lord, who truly show your love, Lord. And we pray that we will become more aware and sensitive to the needs of this group, Lord. We thank you for our speaker, Ms Smriti, Lord, who's here freely and graciously to share her knowledge and experience and skill, Lord. And we pray that you bless her abundantly, Lord, as she leads us in this session, Lord. And may all of us be enlightened in a special way and be changed and transformed in our hearts and our living as we listen to this lecture, Lord. In your precious name we pray. Amen. Okay,
We will be starting with the session now, followed by the Q&A later. We have a wonderful opportunity to hear Ms Smriti Rana ma'am on the topic of care for the caregiver. Ms Smriti Rana ma'am is Head of Strategic Partnership and Community Engagement. She has a Master's of Science in Integrative and Holistic Psychological Counseling with 18 years of experience in palliative care. Smriti ma'am is a speaker at TDX and has spoken on a range of topics related to palliative care on various forums. She has worked in Pallium India for 10 years and has worked in palliative care for 20 years. She has been caregiver to many beloved ones suffering from illness like cancer, respiratory failure, addiction, and mental health issue, a global advocate for equitable access to palliative care and pain relief, especially in India and other countries. We welcome you, ma'am. We are blessed to have you here. Over to you, ma'am.
No, actually, I'll just invite Smriti ma'am to speak. A couple of words. I just want to tell everyone that I personally have studied the palliative care course, the foundation, and the volunteer training program, and I've been truly enriched as a human being in my understanding and sensitivity. And for those of us who are Christians, we are called to serve our fellow human beings, in various ways of need. And this has really made me greatly aware, more than any kind of even biblical training and theological training. This has actually opened my eyes to different dimensions of human suffering. And I would really encourage everyone to consider doing palliative care and get connected with Pallium India. And I really want to appreciate ma'am who's really here to share her knowledge and experience. And it was a great privilege to study under her because she really speaks from her life, from her heart, and her conviction, her her experiences are really make the subject so meaningful. So yeah, over to Smriti ma'am. We are really looking forward to this.
Thank you. Thanks so much, Abhijit and Alishana, and thank you for inviting me to this gathering. I went to a school called St. Hilda's in the Nilgiris for the first 10 years of my life, and prayer was a very important part of that time in my life, which I seem to have not been in touch with that much. So listening to you, Abhijit, just pray for this session for me, I found great comfort in it. I'll also say that since this is a small group, is it okay if I ask for few cameras to be on, just so that there's more of a human connect? Palliative care,
Yes, yes.
palliative care is a very human thing, and somehow technology seems to have distanced us from one another while simultaneously bringing us close to one another. So just for the sake of being able to interact more freely, I will ask for cameras to be on as much as you can. I was very well touched to be asked to lead this session, also because I've had a ringside view to caregiving, and when I first got into palliative care, even before I got into palliative care, my master's thesis was on caregivers, quality of life of caregivers, and that's what I chose to do my master's thesis on. And as much as we advocate for palliative care, I think palliative care is incomplete unless we include caregivers as part of not just who receives the care, but also who we involve in providing the care in a way that is competent and compassionate. Because a lot of the times caregivers feel very helpless. There's a lot of mixed emotions. And because of that, sometimes we find ourselves making very emotional decisions when actually there are ways for us to manage ourselves, our emotions, and also to get the right kind of direction from the healthcare system, if only we know to ask for it. And unfortunately, we have a long, long way to go. So while the health systems continue to prepare themselves to care for caregivers better, there's a lot that caregivers themselves can do in order to help themselves, I think. And I think palliative care is one of those disciplines that really strongly feels about it. I see a lot of familiar names and faces today, so you might find that some of my slides are a little repetitive because you've already seen them before. So I'll try and not spend too much time on those slides, but for the benefit of those who are here for the first time and I'm meeting for the first time, these are all slides that have been extracted from various sessions that we've taken in Pallium India. So if any of them resonate with you, know that there are entire courses that you can do where you can get a much more in-depth understanding of some of these topics. So I'll try and not be too technical, but let me just get started. Abhijit, are my slides visible?
Yes, yes, they are, ma'am.
Okay, all right. So I'll also, put in a little bit of a disclaimer. About 22 days ago, I lost my mother after a protracted illness, and she'd been sick for a long period of time, first with addiction issues and mental health issues, and then with, towards the end, it was respiratory illness. And part of the reason why I'm not in Trivandrum or in the South is because now I'm here in the aftermath, just, also going through a period of bereavement. But I also find that this is as good a time, or as probably the best time for me to be talking about caregiving, because, now it's going to come right from the heart and, and a little less from the head. But we'll also take this time to unpack some of these things. I'm going to use I actually have no qualms about using my personal experiences to illustrate certain points. And although I recognize that my experience might be very different from people from different backgrounds or different, resource settings, I find that some of the elements are quite universal. So please feel free to also, share your experiences, and let's really make this a meaningful hour for all of us. So I'll start off by saying that, there are a lot of myths about palliative care. And some of the most dominant myths are that palliative care is only for people dying of cancer. And a lot of people believe that it's only for cancer. So if I have a motor neuron degenerative condition, it's not for me. If they think it's, it's a disability, or if it's a spinal cord trauma or something, or if it's for a child, it's not for them. But that's not true. Palliative care benefits patients and families from the time of diagnosis right to death for any life-limiting or life-threatening conditions. And I want to highlight life-limiting. Life-limiting is a condition that prevents you from engaging in life fully, and it could be something like a disability. It could be something like a a cognitive condition. It could be various things. It could just very well be that where you live, you don't have access to proper health care, and therefore you're not getting the care you need. And that is what is limiting life for you as well. So palliative care comes into all these scenarios, and I'll tell you a little bit more about it. A lot of people believe that palliative care is the end of the road and they don't want to go there. So it means giving up hope, and therefore I don't want to go there, and it means that there is no more hope for me. The fact is that in palliative care, we really reframe hope in terms of quality of life through symptom management, comfort, and support for the entire family. You're going to be hearing my mother's goose at the back. That is something I've inherited along with everything else. I'm sorry, it's a very noisy bird. Okay. The other myth about palliative care is that it hastens death, that the interventions we use hasten death because for some reason we don't prescribe curative treatment. That is not true at all. Palliative care doesn't look to hasten death. We do look to minimize futile interventions. Somebody who is who's 80 years old, has fourth stage, fourth grade cancer, being put in an ICU, it's a futile exercise, which is actually going to cause the family a lot more distress and suffering. And that is something that we might advise against if that's the case, but it does not equate with hastening death. And even when there is no available cure left, there is still palliative care that we can offer, which is in terms of symptom control and distress management. Pain is a part of serious illness and dying. So you know what, we shouldn't pay attention. If the intervention comes with pain, well, that's just a part of it. This is a very, very serious issue in our country, especially where pain management is not, it's now recently been introduced into the undergraduate curriculum. But imagine going through 5 years of medical school and not learning about pain management. What does that tell you? It gives you the impression that, okay, it's not important, so let's not study it. And also it's a non-examinable subject. It was a non-examinable subject, which basically the system is telling you no points for learning how to relieve someone's pain. So someone who is already burdened with studying for, to become a medical doctor is going to skip over chapters that really don't, allegedly don't mean a lot or don't have a lot of value. And the fact is that pain does not have to be a part of illness and dying. There are some kinds of pain that are harder to relieve. There are some kinds of pain that are unresponsive to current techniques and medicines, but that doesn't mean that we don't have the ability to reduce somebody's pain, if not take it away completely. And we should be asking for it. Now, of course, the problem with that is that the gold standard for pain management is especially in cancer, is morphine. And people have this idea that morphine is administered to hasten death, and morphine will, eventually reduce the lifespan of the person. That is not true. Appropriate doses of morphine really keep patients comfortable. And I don't just mean for pain in cancer. My mother got 5 doses of morphine 5 times a day. I mean, she got 1 dose of morphine 5 times a day to alleviate breathlessness. And I can tell you that just a small 0.25 mg of oral immediate release morphine is what actually managed to keep her comfortable at a time when she needed up to 6-7 liters of oxygen continuously around the clock. So understanding that morphine is not given to hasten death is a very, very important change in mindset that all of us and the medical fraternity need to arrive at. And taking pain medication in palliative care leads to addiction. A lot of people believe that morphine will lead to addiction. And the fact is there is enough and more evidence, which for some reason is not given enough visibility, that appropriate doses of morphine and other opioids under trained professionals who understand the drug, it does not lead to addiction. I can tell you that. And addiction is a whole other chapter, but you can titrate doses of morphine. You can bring it into the way it is administered, like, giving oral immediate release morphine to take back home, but giving IV injections and things in medical facilities. So it can be managed. It's just a matter of us understanding how we can do that. Okay, so there is a difference between what is a disease and what is an illness. Okay, and a disease is really the organic part of it. Abnormal conditions that affect an organism which require treatment. These include infections, they include degeneration of tissue, injury, trauma, toxic exposure. All of these things cause diseases. Diseases are physical and biological in nature. Whereas the illness, we usually use these words interchangeably, but illness is all of the stuff that comes along with a disease diagnosis. The emotions, the distress, the discomfort, the fatigue, the weakness, dysfunction, pain, and illness requires management. Okay, and all of these things require different degrees of management depending on what kind of illness experience the person is having. And a lot of that is determined by their socioeconomic status. It is determined by the amount of support they have. And also illness affects the whole family. So the disease may be in the index patient who's been diagnosed with a disease, but illness is something that the whole family experiences. And disease usually causes illness. But there are sometimes diseases that don't cause any visible illness. Like, for example, if you have high blood pressure, which is treated, which you're getting treatment for, you're not necessarily going to feel all these things in this circle over here, okay, unless you're missing doses and it's not being treated properly. Early stages of cancer, why do so many people present so late? It's because they're not symptomatic. They're not feeling any distress till much later, by which time the disease has progressed. But, and there are some diseases, there are some illnesses, you might feel all of these things without a diagnosis. Okay, and this is what psychologists call somatoform disorders. But really, to me, it is a lack of understanding, because the mind-body connection is so strong. It is so strong. Just because there is no conclusive diagnosis does not mean that the person's distress is not real. And so we really need to pay a little bit more attention. People with chronic pain, pain that does not respond to traditional forms of treatment, after a while, doctors give up on patients like that. They think that they're attention seeking. They think they're, they're just in it for the pain medication or things like that. But the person who's going through chronic pain is really suffering. And the way a person experiences the illness, the emotions, the distress will impact the disease. If I'm too distressed, I've had a horrible experience at the hospital, I don't want to go back to the hospital. So I may not go back for my physiotherapy. I may not go back to, to get another treatment done. So my disease might worsen as a result of that. Non-compliance is a big problem for the healthcare system, where people just stop taking medications. Maybe because it is so expensive and it's causing the family a lot more distress, and they're having to maybe give up a meal a day in order to pay for one strip of that medication. So they rather not go in for that treatment. And so the disease gets worse. And emotions also have an impact on your physicality, as we all know. If you're anxious, if you're upset, if you have very acute reactions emotionally, that is going to have an impact on your disease. Your sleep is going to get affected, your appetite is going to get affected, and then the disease also progresses as a result of that. So this is what Eric Cassell says. He says, disease is something the organ has, illness is something the person has. I'm going to say person and not man. Okay. And illness-related suffering is much more than just physical distress. And here I want to bring your attention to the fact that this is where the caregiver comes in, because the total pain experienced by the patient and the family has various factors. There is, of course, the physical distress of the patient and all the suffering that the patient is going through that is also causing distress to the rest of the family. There is psychological impact of the disease and the illness on the family. People with mental health conditions, it might get worse. There's depression, there's anxiety, there's all kinds of other issues that might surface and also make the whole situation much worse. Communication issues in the family, dysfunction in the family also gets worse at a time like this. Socioeconomic conditions. It's not cheap being a patient in India. It is not cheap. You get diagnosed with a disease, a lot of things change for you financially, and that in turn causes more suffering. I've had to pull a child out of school so that I can pay for my next chemotherapy session. I'm living with that guilt and that sadness also. And as a result, my whole family is struggling. Conflict, decision-making. Okay, I want to spend this money on this treatment, but someone in my family says, but we're not going to be able to afford food for the next few days. So there's conflict between two people who don't really agree on a particular treatment modality and so on. And of course, spiritual distress, which is a loss of, I don't just mean religion, religious belief. I also mean your belief in everything else, like meaning, connection with other people, hope, those kind of things. And what gives you peace earlier you might not have the time for it now. Going for a walk, listening to music, going to church, all of these things, you're so, as a caregiver, your entire time and energy is just fixed or directed at the patient. So illness is a total human experience, and it has physical impact. So even the caregiver might develop other health conditions. They might, from back pain, from constantly having to physically support the patient. It might be just lack of sleep, not looking after yourself, not getting adequate nutrition, not being able to go see a doctor yourself because there's no time or money for it. So many things. Cognitively, it affects the way you process, the way you problem solve, what you're able to pay attention to, your concentration levels, your ability to really focus on a task. All of those things are affected. Those are cognitive functions. Like I said, there is a spiritual fallout as well. Activities that give you meaning and hope, connections with people that you want to be with, who give you support and comfort at this time. All of those things go for a toss. Emotional, of course, there are various emotions associated. Not all of them are good emotions. Not all of them are bad emotions, but you have a mix of emotions, and caregivers go through this real roller coaster. And I will talk about it a little bit more later, but there is guilt, there is anger, there is remorse, there is bitterness. Sometimes there is resentment. So it's not just, oh, I'm here to serve this person. Sometimes there's a lot of negative feelings that caregivers traditionally in India are asked to suppress, because it is not considered socially acceptable to express anything that is negative towards the patient, no matter what your relationship with the patient is. The patient takes center stage. And so caregivers have to take a back seat when it comes to their own emotional management. And of course, there's a massive social impact in terms of your work life, in terms of being able to be with friends, in terms of your extracurricular activities. You might be part of a sports team that really means a lot to you and you can't spend any time with anymore. And socially also, depending on the kind of illness it is, if it is a stigmatizing disease, people start to withdraw. Society starts to withdraw. Or if it's a disfiguring illness, if it's like, say, a head and neck cancer, which is very disfiguring, then you don't want to go out and socialize much. And so those social connections fall away. We created this infographic some time back. So I just want to highlight this thing that, on the left of the screen is this: what is palliative care perceived to be? End of life care. But what palliative care is so much more. We rely on community support, which is why all of you are here this evening, late in the evening on a Tuesday night. And community support is vital because us healthcare workers cannot be everywhere all the time. And no place is better equipped, no person or no group of people is better equipped to support a family more than the community is. And we know that community support can make or break the experience of an illness for a family. Pain relief and symptom management is the medical side of it. We really, of course, that's what the West pays a lot of attention to, but that's also because they've got systems of healthcare that will take care of things like insurance and other kinds of support. We don't have that in low and middle income countries. So for us, pain relief and symptom management is a major chunk, but that's not all. Interdisciplinary care. Palliative care is one of those few disciplines that relies on not just doctors and nurses, but social workers, physiotherapists, occupational therapists, counselors, and of course, volunteers from the community. And we pay equal importance, we pay equal attention to psychosocial and spiritual support, because like I said, especially in contexts like ours, the disease of one person has a multi-generational impact on the family. It's about being prepared for death. Death is a bad word. We don't say death in a lot of our cultures because there's a lot of taboo around it. But if we don't talk about it, then it catches us in a terrible place, and we're not prepared. We don't know how to deal with it. We don't know how to deal with the aftermath. And that really, you might take really good care of your patient for years, but if they're not prepared for their death for whatever reason, then that can overshadow every good memory you've had with that person. And if the person has a bad death, in pain, in a setting that doesn't allow you to be with that person, and they die alone in an ICU, those kind of things really overshadow the entire experience you've had with that person all your life. And it can have far-reaching impact on the way you grieve as well. And of course, family and caregiver support, very, very vital, because it's the people who survive and the people who are surrounding the patient that need as much care. And that's why we're all here today. Restoration of dignity, one of the first and most important things to be stripped when a person gets a disease diagnosis is their dignity, because their dignity becomes second to all the opinions and all the other interventions that are being prescribed. And an overarching thing, we made that the sun in the clouds is empathetic communication, because whether you're a doctor providing pain relief, whether you're a social worker providing psychosocial support, whether you're a counselor talking about death preparedness, whether it's somebody just trying to restore someone else's dignity, empathetic communication has to be at the core of it. If you don't, and it's a skill. I mean, everybody has the ability, and it's a skill that needs to be honed on a regular basis. I mean, just like doctors go back for, continuous medical education, just like that, I think learning how to communicate and maintaining that level of good communication is really, really important, not just to healthcare providers, but also within the family. And sometimes it has to be taught. So I'm just going to, I'm going to share a video with you here, which is a video that was made, it was made in the West. Let me just see if I can get this right. Abhijit, can you just give me a thumbs up when the sound starts playing? Okay? No sound? Okay, let me try again. This is always the case.
No. Yeah.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
I'm just going to be mindful of the time. So like I said, it was created in the West. So you can see that they're focusing more on pain management and medical interventions. I'm a little nervous about where we are with time. So if we're talking about the patient and the family, we of course have to talk about where do we begin. There is the patient's reality, which increasing dependence on other people, loss of confidence, control, feelings of guilt, becoming a burden, fear of suffering and death, loss of meaning or a sense of connection. And as a result of that, there's also what the family's reality is, which is exhaustion, feeling alone, anxious, depressed, uncertain about the future course of action, lack of finances, unable to see or maintain hope. I'm just going to go back.
No problem. I mean, be comfortable in finishing the presentation.
All right. So if we're talking about the patient's reality, they also need Now, if they're going to be increasingly dependent on others, how can we help them? Because that taking away that sense of control and autonomy, suddenly when you have a diagnosis, everybody becomes an advisor. From your family to the doctors, to the second opinions, the third opinions, the uncle who lives 2 villages or 2 towns away and has known some healer there, so he wants you to also talk to that. So everybody has an opinion at that point. But a patient really needs to be able to participate in decision making about their own illness. And they need to be treated with respect. Just because somebody has a disease doesn't mean they stop becoming a person. If they have feelings of guilt, a lot of the times when a patient says, I'm feeling really bad about this, the immediate reaction we as caregivers have is, don't worry, it'll be fine. We don't give them an opportunity to say, what is it that you're afraid of? Tell us what is making you feel sad. Tell us what is making you feel guilty. Let them air it out. And unfortunately, a lot of the times we don't let them do it. And we have to allow them, it's only when they speak up can we understand what dignity means to them. Dignity might mean, I don't want my son to be in the room when I'm having my diaper changed. It could be something like that. It could be that, no, I will not use a walker. It might make life simpler for them, but maybe to them, that's a loss of dignity. So we need to give them that time and slowly encourage them to use that walker if that's what's going, and to let them know that with the walker, they have autonomy, then they can rely on themselves. So there are different ways to have that conversation. Resolve conflicts. There's a lot of that playing on people's minds when they're not well. Patients need to receive peace and forgiveness. And this is not something we just have to wait till the deathbed. Sometimes they're not able to talk or hear by the time they're on their deathbed. So it's important to have these conversations about conflict, about peace, forgiveness. And sometimes we keep patients holding on. Sometimes they need permission to die. And it's not easy to say, okay, if you need to go, go. But sometimes that's what they need to hear. A significant number of people will die when their loved ones are not around them. And that's what happened with me. I was with my mother 4 months nonstop. I stepped away for a few days. She died the night before I came back. And it makes me wonder sometimes, did I make her feel like she needed to hold on? So they need that permission. And like I said, there's a family's reality as a result. There's exhaustion and loneliness and all that. And so what do families need? Families also need to be able to express themselves. And sometimes the dynamic within the family makes it very difficult. But this is the time when sometimes we need to change the dynamic context, the dynamic amongst us, and say, let's have this conversation, which is difficult, I know, but let's try and talk about this. To ask questions and receive answers from healthcare providers, because that's usually a one-way street. This is the intervention, this is the treatment, do this, that's all. But families need the space to ask the questions, even if they think it's a stupid question. Something I tell all the patients I work with, their families I work with, is there is no such thing as a stupid question. It's your family, it's your body. And if you don't understand something, you should be able to ask it. And if your doctor is telling you, you just have to do it, I'm not going to explain it. Well, I would think about that a little bit and maybe think of, getting those answers from a healthcare provider who's able to explain it to me. And as palliative care providers, often we end up becoming conflict negotiators and resolvers. And reassurance, because diseases can be very, very unpredictable. And what reassurance can I give them is that no matter what turn the disease takes, there is always help available. And that's what palliative care usually does. We are the help that is available when there is no cure or when there is no positive outcome from a treatment. And that reassurance that I have not been abandoned by the healthcare system just because my disease is not responding to the treatment, sometimes that makes all the difference to the patient and the family. And to receive affordable medical, nursing, and emotional support, which is a whole other topic. I won't get into it right now. Okay, so why is psychosocial care so important in palliative care, or I would say in any healthcare? It's because, like I said, illness is so unpredictable. And as the disease or the illness progresses, the needs change and stressors change. What was a stressor early in the illness trajectory, it is very different now. earlier I had issues with, say, mobility. Now I have issues with breathing. I still had some savings in the beginning. Now I have none. I have a loan of 50 lakhs that I have to pay. So stressors also change, the challenges change, and the context and the experience of the family changes. And it affects us at every level, from the level of our thought to our emotions, to our social structures, and our sense of stability and our sense of spirituality. Okay, I'm not going to get into these two cases. I'll wait to hear from the rest of the room later. But this is a very psychology-based slide, but I just want to allow you all to, I'll walk you through it, okay? So look at this orange box in the middle. It's what we call the window of tolerance, which means this is a state where you're calm, you're alert, you're able to problem solve, you're clear-headed and you're relatively healthy. And you have stressors in life, but you're able to ups and downs that you're able to navigate with a certain degree of competence without disrupting your sense of well-being too much. And maybe at the beginning, the person is slightly symptomatic, so on. You go to a couple of doctors, it says, okay, he's fine, maybe we should do another test, etc. And then you get a diagnosis. And for a lot of people, we escalate into a hyperarousal state, which is when the sympathetic nervous system comes in, where for different people, we feel different things. Some people feel panic, sometimes people are anxious. There are people who are hypervigilant. They start looking out for, why did you cough just now? There's that sort of hypervigilance. And after that period is resolved, there is a proper diagnosis. There is human tendency to, sometimes swing into a state of exhaustion and a little bit of disorientation because you're recovering from that hyperarousal state. And as the illness progresses, and I'm using the context of illness, but window of tolerance is for any stressor or any sort of life experience. As the illness progresses, bigger and bigger crises start to hit, and people start to spend more and more time in these two states. You're handling the crisis, you're hypervigilant, you're hyper alert, and then boom, you go down to a state of like absolute disorientation or fatigue where you don't want to talk to anybody, you're irritable, and you're a little bit disassociated. And the problem here is that if the crisis is hitting faster and faster and faster, your body doesn't know how to regulate itself anymore. And your sense of well-being gets more and more frazzled. And you spend less and less time in this window of tolerance. So you find that your problem-solving abilities are also getting frayed. You're irritable a lot more. You're losing your temper a lot more easily, and so on. And what we really need to do is try and come back to that window of tolerance, which is not always easy. And there are 3 stages, and this is where caregivers are involved in all 3. Where at the time of diagnosis, it's really important that everybody understands what the diagnosis is. I might be given a diagnosis of idiopathic interstitial lung disease. Do I know what it means? Has it been explained to me that it is it was explained to me beautifully that, normally your lung alveoli is like soap bubbles, but then they harden, they become like a little bit like gel, then they become a little bit like cardboard, then they become like honeycombs. That is what the disease looks like. So I know now what idiopathic interstitial lung disease means and what to expect and what the trajectory is going to look like. Is there a role for palliative care? In my case, I was told right up front that we are already in need of palliative care. So let's start palliation. We will try what other, pulmonary rehab and things can be brought in, but we're already in an advanced stage. I didn't need to go doctor shopping because my doctors explained everything to me properly. And if there was ambiguity in what they told me, then it's likely that I will go check with other doctors. And that's what pushes caregivers to find more and more doctors, a second opinion, a third opinion very often, because they're not getting the information clearly enough. At the time of treatment, similarly, what is this morphine 5 times a day going to do? It's going to keep her breathing steady. It's going to also take away some of the anxiety that comes with a sense of breathlessness. And so it's okay to be giving it. We start low, go slow. This is how it will go. This is when you need to crank up the oxygen machines. This is what you need to do. So it was very, very clear understanding for everybody, which as a caregiver, my stress levels came down. I mean, they were managed much better. assessing the treatment impact on the disease patient and the family. And I'm giving you a good example where I was routinely in touch with the doctors who asked, okay, does this medication work? Was she able to sleep through the night? Has her breathlessness become less? Yes. Okay, so we're on the right course. Affordability in the long run. How long do you think this is going to last? Can you afford it? And if you can't afford this particular kind of treatment, then let's look at something that will have a good impact, but will cost you a lot less. And finally, prognosis. I was asked very clearly, Smriti, what do you want in the end? What does your mother want? And we were very clear that we didn't want to be in a hospital. And therefore, the entire treatment trajectory was said, okay, what will home care look like? What do you need to take care of this person at home? And so we were able to decide on this together. When to stop treatment? For us, it never came to that. But that is something when it comes to curative treatment. When do you stop chemotherapy? Is it really benefiting the patient, or are they spending more and more time in the side effects of the treatment? Are they not able to feed themselves anymore? Are they, is the value of the treatment being overshadowed by the side effects and the futility of it? And where should someone be taken care of? Like I said, do you want to be at home? Do you want to be in a nursing home? Do you want to be in a long-term facility? Or do you want to go to ICU as and when acute exacerbations occur? And for this, people sometimes will just receive medical information from the doctor. This is the disease, this is the treatment. Paternalistic is more, this is the disease, this is the treatment, this is what I recommend. Okay, but shared decision-making is, this is the disease, this is the treatment, this is what I recommend, but what can you afford? What are your preferences? And how do we work with that? And that is what we really need to be focusing on. I'm just going to stop sharing my screen for a second, Abhijit, so I can, skip ahead, because I just want to talk about two important slides before, maybe I can talk about Pallium India a little later, but I want to just do 3 slides before I open the floor. So why?
Covering that part about
Sorry, I can't hear you.
Will we be covering that part of caring for the caregiver, which is the caregiver struggle?
That's what I'm coming to. Now,
Okay.
I think this is a really important part of caring for the caregiver, because we as caregivers need to understand this landscape. Now, caring for the caregiver means what? It's very easy to say, make some time for yourself. Look after yourself, make sure you eat well, you sleep well while you're looking after the person that you're looking after. But why I'm talking to you about this larger picture is that very few caregivers, in my experience, know what their rights are, know at what level they need to be involved. At the time of diagnosis, do I have the full information to be able to make decisions that are financial in nature? Do I have the right information to understand that, okay, if with this medication, I can afford 8 sessions of chemotherapy, after which I will be bankrupt. And I neither complete the treatment, and after that, I'm without a home. So caring for the caregiver, yes, we will talk about the fact that, there's resilience building mechanisms and things like that. But it is also really important, I think, in terms of advocacy, to understand that as a caregiver, these are some of the things that you need to be absolutely aware of. That what is medical decision-making, shared decision-making, and at what point, because a lot of the times, Abhijit, I find that caregivers are afraid to ask certain questions because they feel like they don't have the agency to do it. What I'm trying to share with the group today is that you absolutely have the agency. And today we have a healthcare system that can meet the needs of people from different backgrounds and with different needs. But don't fall prey to this thing of, you have to be financially destroyed in order for the treatment to be effective. And why am I also talking about shared decision making is because we end up having these breakpoint conversations where, okay, the test results have come back, the treatment has failed. Okay, or suddenly a son or a daughter-in-law has to quit their job in another city and come back here to look after this person because they're suddenly dependent around the clock. Those are tough decisions for the whole family. Very, very tough decisions. It breaks up families. And the burden that the caregiver then carries is a lot higher, because there are also, like I said, then resentment and all of those things come in. So what we really talk about, I don't know if you're going to be doing a session on advanced care planning, is that today all of us as people who are relatively in good health need to sit and think about these things. If I have a serious illness, or if somebody in my family has a serious illness, what does good care look like to me? Which one of us siblings will be able to take the time to come and look after this person? And it might seem like, a futile sort of conversation to have, but it is far better to have those conversations now than when you're in the thick of crisis management, when emotions are running high, the sibling that is not in town is trying to overcompensate by being aggressive in their opinions. They're sending money to cover some of the costs, but it's not the money you need, it's the support you need. So it's really, really important to have these conversations at this point as far as possible, because as Dr. Roop Gursahani says, it's always too early until it's too late. And that is something all of us would do well to think about. And talking about caring for the caregiver, I'm going to spend a little bit of time. I know we're almost, we're over time, but I want to really talk about anger, because we are taught, whether culturally, socially, or through our faith, that expressing anger is a negative thing. But a lot of caregivers are caring for somebody who they've not had the perfect relationship with. It has been a conflicted relationship. And it might be, or it might not even be a conflicted relationship, it's a relationship that never existed before. How many caregivers, 80% of caregivers globally are women, and that's true for India. And usually what happens, it's the youngest daughter-in-law who comes and gets posted for around-the-clock care. She doesn't really have a relationship with her in-laws. She might be newly married into the family. In Kerala, we see a lot of this. We ran a spinal cord trauma project where we were supporting people with paraplegia and quadriplegia. And many of them were young men who just had a bike accident, or, people working in plantations who had fallen from, when they were harvesting something or whatever. And young married people, arranged marriage, the wife comes in, she's looking after her husband for the rest of her life. She can't leave him because it's not acceptable, and maybe her conscience doesn't allow it. She's never going to have children. So that part of her life is gone. There's no intimacy. And she is around the clock caregiving. Now, tell me if she is justified in not having, in having some negative emotions or not. And there may be various things. And I know of a family, again, very, very, they were married for 50 years before he died, but he was a dominant man. She was a more subservient wife. He got ALS, and as he slowly deteriorated, his control over her got more. He refused a nurse. He wanted his wife to care for him all the time. And it was a very, very protracted illness. And when he finally died, this lady didn't know what to do with her time, with her life, with her emotions that she was left with. So let's not, I'm going to say this, it might be controversial, but let's not deceive ourselves into believing that caregiving is something that everybody believes is an act that is sacred. Sure, overall, it is an act of service to another person, but it's the late nights cleaning up of somebody, someone not taking their medication, things like that. There will be anger. People give up a lot when they become caregivers. They might give up their careers, they might give up their own family life, they might give up their day-to-day activities, so many things. And so we need to pay attention to this point. And if there's one thing I could talk to you all about caring for the caregiver, is this: please make room for difficult emotions like anger. And why? Because I'm talking about anger only, but there's also anxiety and a lot of other things. And if you don't express this in a safe space, whether within your congregation or trusted people in your community or friends or counselors, this kind of anger will manifest somewhere else. And it will manifest in all kinds of ways, in emotional ways where there's grudges, there's guilt, there might be overreactions, the person has very explosive outbursts, the impaired social relationships, depression, apathy, low self-esteem. And it's very, very important for us to pay attention to these kind of emotions as well. And I'll just stop sharing my screen for now, because if you want to really provide compassionate support to a caregiver, we need to give them the safety to be vulnerable and express things that are otherwise not something that they can express easily. And I will strongly say that if we are supporting caregivers, then we need to also be able to say that it's okay for them to have these emotions. And sometimes these emotions last far longer after the person has passed away. So finding that peace through forgiveness, or finding that peace through saying or asking for forgiveness if this was a conflicted relationship, that is something, especially I will say to this group who I know is so spiritually evolved, that bereavement support also involves creating that safe space to put down some of these really, really difficult emotions that people might have been carrying right through the caregiving experience. So Abhijit, I've gone over time, and I'm going to stop with that. I have other things to say, but then let's just spend the last few minutes with.
Yeah, thank you so much for that wonderful presentation, sharing. Yeah. Okay, this is a time open. We are going to have a very short Q&A. So please go ahead and ask your questions immediately. Those who have anything to ask or any doubts regarding this topic, please go ahead. Yes, Brother Murli, please go ahead.
Yeah, that's it. I'm so thrilled to see Madam Smriti on this call. It just happened that I tuned in, and I'm glad she was here. And this topic is so vast topic, and mere an hour of speaking would be insufficient. My sincere request to Mr. Abhijit is that possibly you can have a series on this particular topic, because different kinds of dimensions we go through psychologically, mentally, financially. For example, caregiving. One thought that happened. It's always too early until it's too late, is what she said. Taking a clue from that point in time, right? Health insurance, for example, is a preparation that needs to be done along with. Although we are talking about caregiving, which is emotional, psychological, mental, and all of those things, I believe planning for insurance, health insurance for these people, is a huge amount of planning. That a thought that came to my mind as a banker. So I thought I'd just share this with all of us. Thank you very much. That's it.
Thank you, Brother Murli. Yeah, Tina, please go ahead.
Yeah. Thank you. First of all, I think absolutely excellent presentation. I just put that on the comments as well. I have just one question because there's, I think, a lot of time. We'll soon be undergoing this 7.5 hours training, right, which is meant for volunteers. So I just wanted to know whether caring for the caregivers is also a part of that. And when we actually go and counsel, be it the patient who's affected, will that also mean that we are counseling the caregivers? Because we're planning to get associated with the Pallium India. So hence that question. Thanks.
Thank you, Tina. And honestly, I've been a little out of the loop, so I'm not sure if caring for the caregiver is part of the module. But I'm sure that if that is a specified need by your group, we can create a set of training series for that, because it is, I mean, in fact, it's still in the mix. We're working on it. We are working on a series of modules directed at caregivers in order to make their practical, and like Mr. Murli was talking about, there's practical aspects as well as, so there's two parts to caregiving. One is direct care, one is indirect care. Direct care is what I do to the patient, give them their food, their medicine, clean them up, give them a bath. Indirect care is what I do on their behalf, managing their finances, taking care of their children, or, all of those things. And we need to make the distinction between the two, because they both require our attention and time. And very often the burnout that a caregiver goes through is because they are not being able to balance these two along with what they need to do for themselves. There's direct and indirect care that you have to do for yourself as well. You also have a job, you also have to manage your finances, you also have children to take care of, you also have, you know, various things that you need to, you might have pets at home like I have, but not being able to balance all these things is also what causes the burnout. So that set of modules is going to hopefully, because we're really drawing a lot from on the ground experience from caregivers to say, where did you struggle the most? And to give practical sort of assistive modules for that. And this is going to be self-learning, self-paced, so that you don't, as a caregiver, I can't expect you to come at 4 o'clock every evening on a Saturday. I mean, things might change for you at home for some reason, right? So these are going to be self-paced modules. So that is coming in the long run, which is going to be a lot more advanced. But if in the immediate future, you'd like to do a couple of sessions with us, we can organize it. That's not a problem at all.
Thank you. Yeah, because I think all that you said, I relate to it so well. I myself am a caregiver along with my brother for my mom, right? So I'm saying, when practically if we're getting associated and we want to start the service should be available, I think it's equally important that some part of it in those initial visits, if we could address the concerns of the caregivers, it will go a long way. Not only for the patient, because yeah, it makes it, more impactful. And I sense that need, what I have learned over the last 3 years by giving my time and becoming a caregiver. If it's more structured, it will really, really be useful. Yeah, that's my feedback. Yeah.
There's one thing that I can just place on the table for you, which is something called a comprehensive geriatric assessment. We've started doing that in our families, especially where there are older people in the family who are not necessarily the registered patients with us. So there might be a 40, 50-year-old person who has an elderly person in the family also with them. Now, while the home care team goes to take care of the person who's been registered with us, whether he has cancer or whatever else, if we find that there's an elderly person in the house, we do a comprehensive geriatric assessment to see where they, like mobility issues, eyesight issues, vital statistics, I mean, like whatever, the blood pressure, things like that, because we're monitoring them side by side, because tomorrow an oversight should not cause us to have 2 patients in the house, especially when the older person is also a caregiver, and they're finding, like, there is someone we know where this 86-year-old couple is looking after their 60-year-old son. Now they have very big concerns about mortality. So yes, if you like, we can have a conversation separately and we can tease out a few specific things to make it a more structured, effective sort of tool for you. So we can do that.
Right. Yeah. Any other question? Any other query? Any other doubt? Any comment? Please go ahead quickly. Yeah. Right. Okay. I think if nobody has anything to ask, I think our attempt as NMBF Coffee was just to light a candle in the dark and help people become aware of this. Definitely, as Brother Murli said, that this is a vast topic, and we would encourage you to join Pallium India and do this course, because caregivers are such a sacrificial people group who are, despite their sacrifice and their pain and their suffering and their tears that they shed, they're invisible. People hardly see them and know them. We directly focus on the patient, and we don't even remember the faces of the caregiver. And when I heard for the first time statistics that women are 80% caregiver, I became aware of so many women in my family who had sacrificed. I mean, till that time, we had not, and the entire healthcare system, how it revolves around men. I find it so unfair, really. And we'll encourage all of you who are here and all of you who will be watching this online to please enroll for the palliative care course and to connect with Pallium India and go ahead and do it. So thank you so much, everyone. I want to thank Sam also, who first guided me to this, and of course, Sachin and Brother Murli also, who are there around, like, connected Pallium India. And thank you above all to Ms Smriti, because she is here like a true committed warrior. Despite her personal loss and in a state of mourning, she answers the call of duty, and we want to, now release her too. And also, we remember you in our prayers, ma'am, that God will comfort you in this time of grief. So thank you so much. Thank you so much. God bless.
Abhijit, I just wanted to, before you close, there are a couple of things. Sunanda, who is our
Okay.
in
Right.
in the central part of India,
Yes.
there is the Maharashtra Volunteers Group, which is left
Correct.
contact numbers for. There's another thing that I want to just mention to everybody else, that apart from the foundation course in palliative care and stuff, there is also a program called Arohan, which is specifically for people with lived experience, so patients and caregivers to join. That's more of an advocacy skill building thing, but that's also where we met Mr. Murli and some lovely folks. So I will also direct you to, it's on the Pallium India YouTube page. It's a recent session we did with Mr. Murli and his colleague, Mr. Sarvanan, about estate planning and will planning. And I think that is an essential conversation. I didn't realize how essential it was till a week after we did it. And so it's really, really important. I mean, that would be one really important resource, which I think, Murli, if you can share with Abhijit, that will be great. And
Yeah.
Abhijit,
This is the one, setting your house in order, right?
Abhijit stays in stone's throw away from my place.
Yeah.
But I'm staying actually.
Setting your house in order is the one.
Yeah. And what really, a thought for all of us is that Pallium India, in association with Hiranandani Hospital in Vashi, opened up a five-bed hospital just last fortnight here in Vashi. So this is for the benefit of all of us on the call here. And going forward, I think we can all contribute to each other, help each other in such a way that we can help so many in need, because Pallium has penetrated here in Mumbai and the light is ignited already. I think it's going to catch on fire very soon in Maharashtra and the rest of India. So I'm glad Sam is here, and thank you very much. Blessed to have you speak to us, and I was encouraged listening to you. Thank you very much. Thank you very much, Abhijit, for all of these things. Thank you.
Right. Thank you, Smriti ma'am, once again, and God bless everyone. Bye. Bye.
Thank you.
Bye. Bye.